Artificial intelligence is increasingly functioning as a healthcare stopgap in contexts where human medical care is difficult or impossible to access. Understanding both the utility and the limitations of AI in these situations is crucial for setting appropriate expectations and avoiding harm. In rural areas, healthcare deserts, and regions with severe provider shortages, AI can provide basic health information that might otherwise be completely unavailable. Someone living hours from the nearest clinic can at least get preliminary information about their symptoms, basic self-care guidance, and help determining whether their situation requires urgent travel to seek care. This is genuinely valuable when the alternative is complete information vacuum or relying on unvetted internet forums. After-hours medical needs represent another access gap where AI currently fills space. Most clinics operate during business hours, but symptoms and health concerns don't respect office schedules. Parents with sick children at midnight, people experiencing concerning symptoms on weekends, or individuals with worsening chronic conditions on holidays can get at least basic guidance from AI when their regular providers are unreachable. This can help people make more informed decisions about whether to go to emergency rooms or wait until regular clinics open. However, we must be absolutely clear about AI's fundamental limitations as a medical substitute. AI cannot perform physical examinations. It cannot order or interpret diagnostic tests. It cannot detect subtle clinical signs that might indicate serious underlying conditions. A skilled physician examining a patient might notice skin tone changes, breathing patterns, movement asymmetries, or other observable indicators that provide crucial diagnostic information. AI sees none of this. It can only work with the information users provide in text, and most people lack the medical knowledge to describe their symptoms with clinical precision. The reliability issues go deeper than just missing examination data. AI systems can hallucinate medical information, producing confident-sounding explanations that are partially or completely incorrect. They can misinterpret ambiguous symptom descriptions in dangerous ways. They struggle with probability assessment and risk stratification that experienced clinicians perform intuitively. An emergency physician knows the difference between this symptom pattern makes serious disease possible and this symptom pattern makes serious disease likely. AI often fails to make these critical distinctions appropriately. Infrastructure requirements also limit AI's effectiveness in many contexts where medical access is already limited. Rural areas often have poor internet connectivity. Low-income populations may lack smartphones or computers with reliable access to AI systems. The same communities most likely to have healthcare access problems are often least likely to have the technological infrastructure to effectively use AI as a partial substitute. This means AI as a stopgap might actually magnify existing disparities rather than reducing them. There's also a concerning risk that positioning AI as a solution to access problems could reduce urgency about actually solving those problems. If policymakers and healthcare administrators decide that AI is good enough for underserved populations, investment in expanding actual medical capacity might decline. This would institutionalize a two-tier system where wealthy, well-served communities have human doctors and underserved communities get AI chatbots. A more responsible approach would involve pilot programs that thoughtfully integrate AI with human support. Community health workers could use AI tools to extend their effectiveness, providing context and clinical judgment that pure AI lacks. Mobile clinics could use AI for patient education and follow-up while providing in-person examination and treatment. Telehealth systems could incorporate AI for initial symptom screening that then connects to human providers for evaluation. These hybrid models acknowledge AI's role while maintaining human oversight and the irreplaceable elements of medical care that require human judgment and direct patient interaction. The fundamental principle must be that AI is an inadequate substitute for actual healthcare access, even as it provides some value in situations where nothing better is available. The goal should be expanding genuine medical care, not optimizing the band-aid of AI assistance in contexts where real care is inaccessible.